Next up, Dr. Lee Jampol from Chicago, Illinois, will go over the fundus exam of each of these white dot syndromes.
Okay. So I've been interested in these diseases for a long time, and let me give you some clues from the examinations that might help. So these are still idiopathic diseases, unknown etiology, although we strongly suspect that the immune system is somehow involved in this. Let's start out with AMPI, described by Don Gass, as you heard. These are usually bilateral, but you can occasionally see unilateral. It has an equal male and female predisposition, which is unusual for these diseases. Plaque-like lesions and resolution within a few weeks. One thing that's confusing to people is that new lesions can continue to appear for a few weeks after the patient's first seen, and that doesn't make it another disease. That's part of AMPI. So here's some characteristic plaque-like lesions, deep retina. Here's once they start to heal, which is usually within a few days, they pigment in the center, and then they can get a little bigger as time goes on. Once it's healed up, it's really a pretty non-specific finding. You see all these pigmented chorioretinal scars. And you could suggest that this might be AMPI, but without the acute lesions, you can't be sure. Here's another case of advanced disease with a fair amount of scarring. So presentation on the left, the whitish placoid lesions. They can go out to the equator occasionally. And then a few months later, you see that they've pigmented, and also the lesions have gotten smaller with time, which corresponds to the OCT, which often shows the recovery of the ellipsoid. When there's a lot of pigment like this, it usually means permanent damage in that area. Here's another case, baseline photographs and resolution, improvement in vision as time goes on in many cases. Here's a very severe case. This might be confused with some other white spot syndromes, but I think that even going out to the equator, you would strongly suspect that this would be AMPI. And this was the most severe case I've seen, where you ended up with all these scars, and acutely this was confused with a viral retinitis. Okay, now let's go on to serpiginous. In our photography lab, they have this picture up of serpiginous. So this is different in that it's chronic and relapsing. AMPI relapses are very rare. Eventually, this is almost always bilateral. And what you often see, which helps you with the diagnosis, are the old scars, and then you have these beautiful new lesions here. Here's another patient, old scarring, very inactive, but a brand new fresh lesion there and there, two new lesions. You can end up with a pattern like this. Some of these pictures were from Deb Goldstein in our place. Here's another patient with scarring. Now, serpiginous is divided roughly into two categories: peripapillary, like this, with recurrences, and then macular serpiginous, with the lesions in the macula. But if you look carefully, you can see that there's been scarring around the disc here before. And sometimes the lesions can look like AMPI, and it takes time to be certain sometimes which disease it is. Usually with serpiginous, it's mostly old scars and only one or two foci of activity, and that patient developed very active lesion there. Sometimes you can see unusual appearance. This patient you never would have guessed was serpiginous, but it pigmented, and the other eye had classic serpiginous, so this is an unusual presentation. All right, let's talk about birdshot a little bit. This disease, sometimes these white lesions are not present at the beginning. You just have a relatively nonspecific uveitis. But with time, in order to make this diagnosis, you really need to see the lesions, and they're obviously very deep. There's no obvious OCT correlate to these as far as I know. Very often they follow the choroidal vessels out into the periphery, although sometimes they're more localized as round or oval lesions. This is a dramatic case showing the lesions extending out at the equator. So when you see that, you're almost always certain that you're dealing with serpiginous. Here's another case with more localized lesions. And we don't have time to discuss differential diagnosis, but there are obviously a lot of things you need to rule out, including TB and sarcoid. And once the lesions are inactive, usually from your treatment and not by themselves, you get more atrophic scarring, as you see here, and in the other eye. Okay, now persistent placoid, we described a number of years ago, and this patient came into me with bilateral symmetric white lesions. And I said, this looks a lot like macular serpiginous, but it's hard to believe that you would have very symmetric lesions like this. And I actually sent this patient down to Don Gass, and he said he agreed it didn't really look like serpiginous from the presentation. Now, the characteristic of this disease with time is that CNV is often a very severe problem. This is 5 months later with a lot of CNV. But if you look carefully, you can still see the white placoid lesion. So here's presentation, and here's the lesion later, still with the whitish changes, but on top of that, the CNV changes. And this is 9 months later, and you can still faintly see the whitening from the original lesion. Here's a patient on presentation. If it's not bilateral, almost symmetric, you may have the wrong diagnosis. Here's a patient that was bilateral symmetric, but over the 4 weeks you can see that some of the lesions have grown and some new lesions have appeared, so that doesn't rule out persistent placoid. Okay, but what you have to have is persistence of the changes over the whitening lasting a long period of time, the frequent development of CNV is the blinding cause of the disease. Okay, now MUDES was the first one of these that I got interested in a long time ago, and I show this slide first because this really helps when you have a young female complaining of flashes and scotoma in the temporal field. If you look in and you see this fovea, you have your diagnosis, and I'll show you better pictures of that. So the scotoma is often around the disc, but the foveal change is, I would say, pathognomonic of this condition. There it is. And here's another patient with the foveal lesion, slightly off-center, but scattered white dots away. And peripapillary activity is very characteristic too. And this patient developed changes in the lesion. These lesions faded, and new lesions appeared over the next few days. And here we have, you may have very faint lesions, and in fact you may have MUDES without any white lesions. We've described that just with the foveal changes. Here's another classic case. Now sometimes in the periphery you can get a little bit of pigmentary mottling, and you can now sometimes see scarring from the lesions. You also can get a retinal vasculitis, as you see here. And this patient had MUDES but was confused with optic neuritis. It was a young female. By the time I saw the patient the next day, the patient had already received 1 gram of methylprednisolone intravenously. But if you look carefully, you can see the white spots and the fovea also. And the interesting thing is that methylprednisolone got rid of the disc edema within 24 hours. So I think this is a steroid-responsive disease, but I would not treat these patients with steroids. They all get better, with 1 or 2 exceptions. And here's the patient presentation, and a few months later, normal fundus. Okay, multifocal corditis. I love this slide because it shows many of the key findings. First of all, you have these peripheral lesions. They don't have to be there, but when you see this, you have multifocal corditis or maybe histo. But you also have the punched out spots, which can be from histo also. And you have the peripapillary activity with CNV. So those are all the things that you expect to see with multifocal corditis. Unlike the previous speaker, I think that PIC and multifocal corditis are the same disease, and the lesions are really indistinguishable except by their location and the severity. And we have patients with PIC picture in one eye and multifocal in the other eye. So PIC lesions are in the foveal macula area and often lead to terrible scarring like this, as you see here, from CNV. Whereas multifocal corditis we think of as in the periphery, but there's such an overlapping spectrum in all respects, demographics, etc. Here's multifocal corditis with peripapillary changes in CNV in the macula, and it can lead to scarring around the disc. And you also can get evanescent white spots with multifocal corditis. They look different on OCT. I don't know if you'll hear about that today, but they can disappear without scarring. Okay, here's the scarring of the PIC lesion. So finally, we have the Azor. I think this is a wastebasket diagnosis, and I think it's going to turn out to be different diseases. But we've tried to describe the appearance. So the end stage or inactive Azor is easier to see. You have peripapillary atrophy. You have a curvilinear edge along the lesion. It's almost always contiguous with the disc. Okay, but sometimes it's much more subtle than that during the activity phase. And here's a patient that has a variant of Azor, acute annular autoretinopathy. And this really wipes out the retina in the same way, but this line disappears really rapidly. So I think a lot of our Azor cases probably have whitening like this. But by the time we see the patient 3 weeks later, in this case, the white line was completely gone. And here's another example of that. So Azor is undoubtedly the most difficult. If we had an hour, we can show you all the clinical appearances, but I think that should be distinguishable from the white spot syndromes because they really don't, Azor really doesn't have white spots. Okay, thank you.